They're the ones who raise the bar. The ones dedicated to providing care in the most demanding of circumstances. The ones that understand the healing benefits of kindness and compassion. They're the people of Sarah Bush Lincoln, and they set the bar high. Sarah Bush Lincoln, trusted, compassionate care right here close to home.
Carl is redefining healthcare around you, innovating new solutions and offering all levels of care when and where you need it. Investing in technology and research to optimize healthcare, Carl, with Health Alliance, is always at the forefront to help you thrive.
Meeting the ever-changing healthcare needs of our communities, Paris Community Hospital Family Medical Center is now Horizon Health, with the same ownership, management, providers, and employees. Horizon Health provides patient care and promotes wellness to the communities of East Central Illinois.
At HS St. Anthony's Memorial Hospital, we are at work transforming heart care, rebuilding knees and hips, delivering new generations, and focused on providing health care to you. We are HS St. Anthony's Memorial Hospital.
Hi, thank you so much for joining us today for this episode of Being Well. I'm your host, Key-Ann Armstrong, and we are going to be talking about a variety of health issues concerning women's health, and we're going to focus primarily on pap smears and abnormal bleeding. And joining me today is Dr. Maria Horvat with Horizon Health. Thank you so much for coming today.
Thanks for inviting me.
This is a really important topic for women and for the loved ones in their lives to understand some things that are happening in their loved ones' lives as well. So.
Right. Well, there's a lot of what we're going to talk about today are common problems that I see in the office. So I thought it'd be a good topic to talk about because it probably affects a lot of different people, or certainly people have experience with these various things we'll get to, and hopefully people will learn today.
Yeah, I think so, because lots of women struggle with abnormal bleeding, which is a pain, really. If you want to get right down to it, a literal pain.
Literally a pain in more ways than one.
Yeah, so let's talk about that. I want you to start to lead the conversation here. What's some things that people bring to you for concerns when it comes to abnormal bleeding?
Well, there's a lot of different approaches to abnormal bleeding. So we can have a young patient, somebody who's 11, 12, 13, 14, that the mother will bring to me with heavy menstrual cycles. Mm-hmm. And for instance, most recently, I had a patient with that, and maybe the problem can be solved with birth control pills, even though it sounds like they're very young, but you can place a young adolescent on oral contraceptive pills to control the heavy bleeding because they're missing school. But the other thing you got to think about, do they secretly have von Willebrand's, or do they have hemophilia that's not diagnosed? So you also have to be thinking of those particular problems. So one form of bleeding in that age group is just, they have regular cycles, but it's heavy. And then there's the other group in the adolescent group that has abnormal bleeding in that they'll go 4 months without a cycle, and then they'll bleed for 42 days, and then no cycle for 9 months, and then finally some sort of cycle for 14 days. And that can be a sign of you're not ovulating the way you're supposed to. It's dysfunctional. Mm-hmm. And a lot of those patients might have polycystic ovarian syndrome, which is a common cause in that age group to have that sort of irregularity. Another reason for that sort of irregularity may be just that their hypothalamic system between the ovary and the brain isn't quite developed yet.
Is that due to their age?
Due to the young age. Just like if you have a daughter who's 11, 12 and starting her periods, it might be irregular first, but then by the time they're 13, 14, it becomes more regular. But if it's not, you got to think that's abnormal bleeding. The other concern in the younger adolescent group would be they're not having menstrual cycles, and that can occur with ballet dancers, long distance runners, because they don't have enough fat to have a regular cycle. And those patients need to come in. Usually we put them on birth control pills because when they don't have a period, it means they're not getting enough estrogen. So in that age group, either you're having regular cycles Or you have the opposite, not enough cycles, but then prolonged bleeding, or you're having semi-regular cycles with heavy bleeding. So that's all abnormal bleeding problems that we can help you with.
So are there tests to help you diagnose, one from the other and what may be going on?
There is. So one of the things that's really helpful when someone comes in is to have a menstrual calendar. To come in, and a lot of times people have, I think in December I had a period, but I didn't. But if it's written down, it's so extremely helpful to see what the pattern is. So that's number one. I need to see how long has it been going on and what the pattern. And then usually with a young woman, it's blood tests. There's blood tests to help you determine if there's polycystic ovarian syndrome. There's blood tests to determine if you have some sort of bleeding disorder that's been undiagnosed so far.
Okay. Now, are these things that can be handled primarily with birth control, like you said? Is it something that's long-term? Is it curable?
Well, PCOS, which is polycystic ovarian syndrome, is incurable. You pretty much have it, and there's nothing you can do to take out the genetics of it. And so usually to manage PCOS, we approach the symptom. What's the symptom? Irregular periods and probably birth control pills would be the answer. Hirsutism, which is a lot of hair growth, birth control pills can help with that, and there's another medicine called aldactone. So it depends what the symptom is. Or maybe you're a little bit older and you have PCOS and you want to be pregnant, and you go 9 months without a cycle. You're not going to get pregnant if you're not ovulating. Then the treatment's a different approach. So it kind of just depends what the particular problem is with PCOS. If you just have run-of-the-mill heavy cycles that some people have, and there's nothing necessarily wrong, but you have heavy periods, probably the best option would be to go with the birth control pills, because that will decrease the flow at least 50% if you're on the right pill.
All right. With the abnormal bleeding and the heavy bleeding, I mean, it's such a struggle, to deal with, and then sometimes you don't know when it's going to start, and sometimes you don't know how long it's going to last.
Right.
I mean, it's really an emotional roller coaster too.
Yeah, for a lot of people it really is. And some people, let's go to the next age group after the adolescent group, and then we go to the next age group, pretty much you can say 17 to menopause. Then you have patients that just bleed super heavy, and there's more options for treatment for those patients, and we should talk about that a little bit. And pretty much if you're changing a pad or tampon every 2 to 3 hours, that's pretty much on the heavier side. Sometimes patients will come in and they'll think the period's heavy, but they're changing 4 pads a day. If I quantitate that, it's probably not that much, changing a pad or tampon every 6 hours. But really, if you're changing every 1 hour, 2 hours, 3 hours, I have patients that have to change every 30 minutes. And they're staining their clothes. They are staining their sheets at night. And those patients should really come in to talk about options.
Well, because it's affecting their life.
But
they can't really live because this is such a drastic thing happening to them.
And I don't have the exact numbers, but the time off of work and the money that it costs with time off of work actually goes into the hundreds of millions of dollars in the United States. And so to control heavy bleeding, it just buys you your life back, unless you're happy being at home, sitting, having a heavy period.
Which nobody is.
No. So you want to go to the ball games, you want to live your life, you want to go to the wedding without,
And feel good.
Yeah, and feel good, not be anemic, and that sort of thing. So the workup when somebody's older, again, the menstrual calendar kind of helps me determine a lot of different things, and there's 2 types of abnormal bleeding. There's ovulatory bleeding, meaning you're ovulating, you're having pretty much a cycle every 25 to 35 days, which is considered fairly regular. Not everyone's a perfect 28 days. And those patients tend to have more anatomic problems, such as a fibroid, which can cause heavy bleeding. Another reason for heavy bleeding would be adenomyosis, which is actually endometriosis into the wall of the uterus. And those uteruses tend to be a little bit enlarged, a little soft and boggy if I do surgery on them. but those would be the anatomical reasons for heavy bleeding. Polyps can cause heavy bleeding, but you got to think off the grid sometimes. What if you haven't seen a doctor in a while and you have cervical cancer and that's why you're bleeding? Then there's anovulatory bleeding, which means it's unpredictable. You're bleeding for 42 days in a row.
That just sounds miserable.
It is, and I've had patients, they come in, their hemoglobin's 4 or 5, and I have to transfuse blood, get the situation under control in a short run, and then decide upon a plan.
Yeah. So people should really go to the doctor regularly and get their annual checkups.
Right.
To make sure that they know what's going on with their body. And if they are struggling with something like this, that there are answers and there could be help for them.
Right. And then I stress again the menstrual calendar, maybe little notes, super heavy today, or super heavy, for 3 days, because that gives me a clue that I should start a workup, which we should talk about. In the average adult woman, the workup would be make sure you're not pregnant and we're not secretly dealing with a miscarriage or something of that nature. B, what's your blood count? Are you anemic or not anemic? C, I always get a thyroid test to see if somebody's hypothyroid. Usually it's normal, to tell you the truth, but I still check it. And then D, I always get a sonogram to see what the size of the uterus is and see if there's any big fibroids or something of that, something unpredictable. I also have to make sure you're up to date on your pap smears. I might want to do something called an office endometrial biopsy to make sure the lining is okay.
Okay.
And what that entails, it's usually a separate office visit, the speculum's in the vagina, and I have to pass a small pipelle into the uterus and obtain just a little bit of tissue to send to the pathologist.
All right. So do you do that like a pap smear is done, or explain, the pap smear, the procedure for that? Because there may be younger people watching, who, or pass this information on to help explain it to someone who's never had one.
Yes. Well, the pap smear and the endometrial biopsy are two different things. So pap smear, most people would be familiar, but if someone's watching that's younger, what it entails is we place a speculum into the vagina, and then we can visualize the cervix, and then we take a swab of the cervix and send it to the laboratory. And at the lab, in the old days, it was called a pap smear because literally it was a slide with a smear, and we fixed it with hairspray or a fixative. And a human being would be looking at that smear, but now it's computer. It's all, if you notice your pap smear specimen, we swirl it in a little cup, and it goes to a lab, and with computer technology, they're picking up the abnormal cells, and it's actually improved on, there's less false negatives, so we're getting more true positives by doing that.
Yeah, which is good, because when you get something that's concerning, then you're thinking, oh my goodness, there's something wrong, something really wrong. But then sometimes you go back and it comes back okay the second time, and that was worry for nothing.
Yeah, and that can definitely happen. And then an office endometrial biopsy is different because the speculum's in the vagina, but I have to go higher up. And so I would say it's more uncomfortable, but you definitely have to go higher up and get that tissue to make sure everything's
it's gonna pinch.
Okay. Yeah, I like the little pinch. I give local anesthetic. Not all doctors do, but I do because I personally wouldn't want to feel so much of what's going on. Local anesthetic is always a good thing, I think. And we'll get back to the pap smears in a bit, but going back to the heavy bleeding, so options when somebody's older are, in general, there's a shot called Depo-Provera, but a lot of it works well. It can stop your periods. You come in every 3 months. The problem is some people have an increased appetite and can gain weight, so a lot of people don't like that. Birth control pills can be okay, but if you're over 35 and smoke, you can't take the birth control pill. If you have hypertension, you can't take the birth control pill. So there's a lot of contraindications to that. So we just, that's something that you have to discuss with your doctor about that. The third option would be a great option for a lot of people is the Mirena intrauterine device. It's one of my favorite choices for stopping heavy bleeding. It provides contraception also if you need that, and it will stop your heavy bleeding. The side effects are some people can have irregular spotting, and then some people can say they can feel it. But having done this for a long time, I can say 85% of people are satisfied. Another option would be an ablation procedure where we actually burn the inside lining of the uterus. But we need you to be in the operating room to do that. And but some people do in their office, but you still have to have anesthesia in the office. I personally do in the operating room because that's the setup that I have currently.
Is it considered outpatient? Do you go home that same day? Okay.
It's an outpatient procedure, and what it entails is preoperatively, your biopsy has to be okay, your pap smear has to be normal, your ultrasound has to meet some criteria. The other thing is you need permanent contraception, so you can't, you should not get pregnant when you have an ablation, and I'll get into that in a minute, but either you have to have a tubal ligation or your partner has to have a vasectomy.
All right.
And the reason is once your uterus is scarred and burned in the healing process, if there was a conception, it's not going to grow normally. You can have an ectopic pregnancy, or it could be up in the corner of the uterus and it can't grow, and it could actually blow out the corner of your uterus because it can't get into the uterine cavity. It's almost a complete disaster.
Right.
So you really have to make sure that you are done having children before you have an ablation.
Right. Or if you are planning to have children, maybe talk about some of these other choices before you get to that point.
Absolutely.
And maybe that can come later down the line.
Right.
If you still need it.
Yeah, birth control pills, the Depo, and the Mirena IUD is really great for somebody who's not quite sure if they're going to have more children, because all of these things are reversible.
All right. Now the Mirena ID, do you still have a regular period if you have that?
No, it stops.
Okay.
But one of the side effects before your period stops is you might spot, and it's more annoying than it's heavy. And it'd be really rare. I mean, maybe a couple times I've had a patient expel the IUD because of the heavy flow, but maybe once every 2 years that would happen. And I place a lot of these.
Okay.
And then with these options, a lot of people come and say, well, my mom had a hysterectomy, my grandmother had a hysterectomy, and I can tell you in the 90s, and I was in this area in the 90s, I would say 6 to 14 hysterectomies a month, it just depending what was going on. Now it's one hysterectomy like every 2 months. It has markedly decreased the need for hysterectomy.
Wow.
Yeah. With these more modern outpatient, mechanisms.
Yeah, there's a lot more choices these days.
Right. Yeah, there's still a role for hysterectomy, but it's really decreased because these non-invasive ways.
Well, speaking of hysterectomy, and you mentioned pap smears earlier, I mean, is there a need for women to still have a pap smear after they have a hysterectomy?
Depends on the reason that they had the hysterectomy. So if you had it for benign reasons like just abnormal bleeding, chronic pelvic pain, fibroids, you do not need a pap smear at all after that hysterectomy. If you had a hysterectomy for endometrial cancer or cervical cancer, you need to continue to have pap smears.
You mentioned birth control pills could be started at age 11.
Or I probably would hesitate. I would probably say more like 12 and a half, 13.
Okay, a little older.
Yeah, a little bit older.
Okay, and then is there a point where women need to stop taking birth controls?
Oh,
pills?
Yeah. Well, not really. So this is the thing about birth control pills. So a lot of people, they think they need a break. I've been on it for 4 years, I need to take a break. You don't need to take a break. So in terms of future fertility, when you want to have a child, you stop the pill, and some people start to ovulate in 1 month, but sometimes it takes up to 9 months before you're having regular periods after being on the pill for a while. So that can be, you have to put that into the equation of when you want to stop. But the pill's actually protective against ovarian cancer, and it's protective against uterine cancer.
Okay, that's good to know.
And so there's no reason to stop. And I have some patients as they're transitioning through menopause, let's say you're 50, you're having bad periods, you don't smoke, and your blood pressure's okay, you can go on birth control pills.
Really, at 50?
Yes.
And for people who haven't reached that point in time where their body's changing and is done with that part of your life.
Right.
Really, it's,
But I use a lot of oral contraceptive pills. Let's say someone came in, they had heavier menstrual cycles, we did our workup, nothing's wrong, they're busy, don't want to do the ablation, and there's nothing wrong with being on the pill until you transition to menopause.
yeah.
And so a lot of people don't know that that's definitely an option.
Okay.
Yeah.
I want to go back to something you mentioned earlier. It just came back to me what I wanted to ask you about fibroids.
Yes.
Those can be removed as well.
They can. And so if someone's going to have a myomectomy, usually that procedure is done more if you're preserving your fertility.
Okay.
A myomectomy is actually much bloodier and technically more complicated, especially if you're doing it through the laparoscope, than just doing a hysterectomy. Because what happens is you scoop out the fibroid and there's kind of a raw surface where the fibroid used to be, and you have to put it back together. And there can be more blood loss with that than the plain old hysterectomy. So if someone's done childbearing, I probably would say, why don't you just do the hysterectomy? But if you're going to have more children, then I would say, yes, just do the myomectomy is the name of the procedure.
Okay.
And sometimes people have fibroids not just on the outside of the uterus, but inside the uterus. And that I can approach vaginally, and using certain equipment, I can remove a fibroid inside, whether or not you're going to have more children or not. And sometimes that can help some patients too. But if it's on the outside, let's say it's a 5 or 6 centimeter fibroid, you'd have to look at your future fertility and what your wishes are.
Yeah.
Yeah.
So more choices, decisions.
Yes,
to
more
make.
choices. Yeah, and the other choice we haven't even talked about is there's an embolization procedure where you can have emboli that the radiology department send to the fibroid, and it causes it to become necrotic and shrink up.
Oh.
Yeah.
Isn't
And that
that
can help some
something?
people. Yeah,
Yeah.
It's interesting that
It
that
is
can be done.
so many different things.
Yeah, there's
Yeah.
definitely options.
Well, we have just a couple of minutes left. What have we not covered yet?
Well, the pap smear schedules, we haven't gotten to that. So
Okay.
the age for the first pap smear is 21, which
Right.
is a big change from, you would start as soon as you're sexually active. So now we wait to you're 21. And then it's every 3 years as long as your pap smear was normal.
Okay, so you don't have to go every year now.
Well, you have to go in for your annual exam.
Oh, okay.
But the pap smear is just a lab part. So we
Okay.
might not send the pap smear
right.
every year, but we still want to see you in the office
Okay,
every
so don't
year.
skip it.
No,
go every
no,
year.
no. It doesn't mean you get to not
Right.
skip seeing
Well, it's not
me.
something people really look
No.
forward to. You know, you're like, oh, I got to go do this, but it's something you need to keep in check.
Yeah, well, everyone who comes in, even this morning, someone's like, I hate this. I'm just like we all do, and I'd probably be disturbed if you said you liked it. So it's like, I know, it's like going to the dentist, or like for me to go to the dentist. So I know that, you know, it's not our favorite thing, but we do have to take care of ourselves and get it done. But anyways, the pap smears are every 3 years.
Okay.
And if you're a normal pap and HPV negative, you can go every 5 years. In my book, that's a little bit long, but the studies say we can do it. So the maximum I'll go is every 3 years.
Yeah.
That's what I'm comfortable with.
Okay.
And we'll have to see you more often if the pap smear is abnormal. And if it is abnormal, you'll get that phone call that it's abnormal, that we need to see you back and do a procedure called colposcopy, where the speculum's in the vagina, and I place a vinegar solution against the cervix. Abnormal cells pick up the vinegar solution, so it turns white with the vinegar. So I know what I'm aiming for when I do a biopsy, and I'll take a few biopsies, and that tells me for sure if something's abnormal. So if you get that phone call that you have abnormal pap, it's really a red flag. It doesn't tell you what's wrong. The biopsy, the actual tissue biopsy, will tell me if you need further treatment or if we can just watch you.
All right.
Yeah.
Well, I'll tell you what, this has been so informative, and being a woman
Thanks.
myself, I mean, just knowing that there's choices out there, you don't have to put up with this in your life, and,
No.
and knowing that you can, you know, make a change is really, really helpful. I really appreciate you being on the show
yeah.
today.
Well, thanks for
So,
inviting me.
Yeah, thank you.
Yeah.
And we hope that you have received some helpful information in this episode of Being Well, and we hope to see you next week.
At HS St. Anthony's Memorial Hospital, we are at work transforming heart care, rebuilding knees and hips, delivering new generations, and focused on providing health care to you. We are HS St. Anthony's Memorial Hospital.
Meeting the ever-changing healthcare needs of our communities, Paris Community Hospital Family Medical Center is now Horizon Health, with the same ownership, management, providers, and employees. Horizon Health provides patient care and promotes wellness to the communities of East Central Illinois.
Carl is redefining healthcare around you, innovating new solutions and offering all levels of care when and where you need it. Investing in technology and research to optimize healthcare, Carl, with Health Alliance, is always at the forefront to help you thrive.
They're the ones who raise the bar. The ones dedicated to providing care in the most demanding of circumstances. The ones that understand the healing benefits of kindness and compassion. They're the people of Sarah Bush Lincoln, and they set the bar high. Sarah Bush Lincoln, trusted, compassionate care right here close to home.